This is the Lunch, Learn, Link seminar series. It's sponsored by the Maryland Cigarette Restitution Fund research grant at Johns Hopkins and the Sidney Kimmel Comprehensive Cancer Center. So what amounts to 1 or 2 times a month during the academic year, we have speakers come in and talk about various aspects of cancer prevention and control in particular, and sometimes a more basic science presentation as well. So today we have a speaker from the Cancer Center. Peng Huang has a appointment as associate professor in the Department of Oncology and is a member of the Biostatistics and Informatics Center at the Cancer Center. She has a connection to the School of Public Health. I'm not, sorry, Peng, I'm not sure if it's a joint appointment or yeah, okay. And so she is well integrated into the biostatistics enterprise here. And she brings today an experience with evaluating CT scans for lung cancer. And as many of you know, the PLCO, the prostate, lung cancer, colorectal, and ovarian cancer trial actually found that it was of benefit to screen at-risk individuals, basically at-risk being former smokers who have at least 15-year history of smoking, or a current smoker with that amount of smoking history and being over age 50. And so the U.S. Preventive Services Task Force has rated low-dose CT screening as an important screening test, evidence-based, and one that should be recommended to these at-risk patients. In terms of public health, we really haven't encouraged the uptake of the low-dose CT scan in a broad way. So actually very few individuals still are not taking up the screen. So one of the issues is smokers are reluctant to learn more and to become engaged in a web of health, where they might be advised to quit smoking. So it is those who are ready to quit who get screened, or those who have already quit smoking. And then there is among the professional community the concern that we may identify individuals inadvertently as having a cancer when they do not, or missing cancers when we should have picked those up. So that's where Peng's work and presentation today comes in evaluating the low-dose CT screen so that we get better and better at making a diagnosis. So Peng, I'm going to turn it over to you.
Thank you for the for having me to present my some of this work here. So we use this artificial intelligence approach to, what's this? Okay. So we, yeah, okay. So we use this CT imaging textual feature analysis apply this approach to the lung cancer diagnosis. So the CT imaging texture features were extracted using artificial intelligence pattern recognition techniques to mimic humans' readings. So lung cancer is the leading cause of cancer death. The survival rate for lung cancer depends on how early the disease was diagnosed. So when the disease was diagnosed early, when tumor is still localized, then the survival rate can be as high as 55%. However, if it's diagnosed late, when the disease has metastasized to other organs, then the survival rate is dramatically dropped to only 4%. So currently, only 16% of patients are diagnosed early. So early diagnosis is critical to save patients' life. The national lung screening trial has reported that 20% of mortality reduction from this low-dose CT screening. So these findings has led to the recommendation of this CT screening by many U.S. care systems. So although these findings are quite promising, there are some concerns. As pointed out here, that patients who undergo the CT screen in attempt to find early-stage lung cancer, we are not sure whether they could receive more benefit than harm. So what are the concerns? Here are the top list. Low positive predictor value and high false positive results, and OR diagnosis, which means those detected lesions may have never become symptomatic or progressed. Because the high false positive rate, a large number of benign nodules were detected from the CT screen that lead to additional unnecessary radiographic and diagnostic procedures, as well as increased mortality and morbidity associated with further invasive testing. In order to reduce this high false positive, first we need to know how the imagings are read. So currently, those imagings are interpreted mainly based on the lesion size, and that is the primary risk criteria to report CT imaging positive. So long read is commonly used rule used by the radiologist. Because the nodule size is the dominant contributor to the positive CT imagings, so it is very natural to think if we could increase this threshold to the nodule size, we could reduce this false positive rate, which is true. But also, you also sacrifice the sensitivity. As shown here by Peng's group, they evaluated a number of ways to modify these rules, and they find the false positive rate was reduced, but the sensitivity was also reduced. However, this PPV value remains low no matter how you modify these rules. The screen detected nodules, their management and follow-up scheme is also based on primarily based on the nodule size, attenuation, and how they look like a shape. So as shown here in NCCN guideline for solid nodule and non-solid nodules. So nodule size is often considered the single most important risk factors. Big nodules is often associated with higher risk of malignancy. For small nodules, less than 20 millimeters, their malignancy potential is highly variable, ranging from 1.5% to above 60%. So there's some limitation for this nodule size rule-based approach, because nodule growth could be asymmetric. It could confound it with benign inflammatory from the infection, such as those we see from the granuloma. Beside the nodule, the margin is also an important risk factor. Nodules with a spiculated margin or lobulated, as shown here, usually have higher risk of malignancy than nodules with a round shape and smooth margins. Attenuation is also an important risk factor. Nodules with ground glass opacity usually has a lower malignancy potential compared to nodule with a partial solid and solid nodule. We know that the tumors are heterogeneous at the histopathological level that lead to the disorganized growth pattern. So such patterns actually is available. This information is available in most of the diagnostic imagings. In fact, radiologists often utilize this information when they interpret the imagings. The limitation of these human readings is that the interpretation, the conclusion mainly based on this visual appearance. However, many imaging features cannot be visualized by human eyes. This limitation can be overcome by using computer-aided imaging texture analysis, because it can identify subtle changes in heterogeneous patterns that are difficult to discern through the visual inspection. Because the imaging usually gives us more information than just size and attenuation. And those large amount of information usually is difficult to process in our human brain, but the computer can do that very easily. Over the past decades, numerous papers have published to show that the CAD, computer-aided diagnosis, and the features extracted using this CAD, they are associated with the cancer outcomes. However, in spite of this work, these techniques has not been translated into the clinical practice. So what are the hurdles? Here are our understanding. First, it's not clear whether the textual features extracted from the CAD could provide additional information as compared to those what we already know. During this development of computer-aided algorithm, multiple optimal cutoff values are often used without the validation. This could lead to overestimate results and a large inflated type 1 error. So in order to translate this CAD approach to clinical practice, a direct comparison is needed to show that the CAD actually gives a better diagnosis accuracy than the radiologist's reading. So based on this thinking, we conduct the texture analysis using NLST imagings. So our sample was selected by informatic management service team who manage the NLST data for the NCI. So we take the matched case control study in order to evaluate the added value. And we control those potential confounding variables, those risk factors are commonly used in current clinical practice. So here's our inclusion-exclusion criteria, how we select the NLST participants. So basically, we select those people with a positive CT screen, with the nodules that are non-calcified and without water and fluid, and they have imaging conclusion readings positive. And we match this imaging, so we only look at those people with who received the lung biopsy. So we match the lung biopsy positive with the biopsy negative in terms of these commonly known risk factors, like demographic factors and CT imaging looking, using this known tumor characteristics like nodule size, attenuation, and the shape. So this is a diagram how we select our samples. So we start from everybody who received the CT screen in an NLST. Then we identify all those who met our inclusion-exclusion criteria. And then we further limit our sample to those 810 people who received a lung biopsy. So then we match the cases, the biopsy positive with the biopsy negative controls. And this gives us 201 matched positive pairs. And then we take a random sample to 134 pairs from here, and then we further downsize our sample to those nodules with size less than 20 millimeters, because these are the nodules that are most difficult to classify, and that they are the major source of the false positive. So this gives us 90 biopsy positive imaging subjects and 96 subjects with a biopsy negative. And then we randomly select 70 pairs to form our training sample, and the remaining 46 as our validation sample. Our imaging processing includes the first step, that the long segmentation, followed by the nodule segmentation using a single-click semi-automatic segmentation approach. So we extract a variety of imaging texture features using artificial intelligence approach. So here are the different types of imaging features we extracted: structural, statistical, model-based, and transform-based. So imaging features were extracted from different regions in the lung. From inside the nodule, that's within the segmented nodules, and surrounding lung parenchyma, that's a period nodule, and also from the entire lung to capture any abnormality from the lung. So inside the nodule, the segmented nodule, we extract the vessel intensity, texture features, shape and size, and wavelet filtering. And the peri-nodule features include like speculation, margin coarseness, pleural thickening of this list. So basically, we capture any abnormalities surrounding these nodules. And also, we segment this like emphysema or these features to capture the abnormality in the entire lung. So here are those technical details how we calculate this. So our diagnosis accuracy was evaluated using 3 approaches. First is the area under the ROC curve. And also we compare our CAD approach with the readings from the NLST trial investigator. Because the NLST trial is more than 10 years old, so we also compare our approach with the readings of 3 experienced thoracic radiologist readings using the current clinical practice guideline. So before we compare our approach, we first see how our cases and the controls are balanced in terms of known risk factors. And this table shows they balance pretty well in terms of known demographic risk factors in age and smoking status. And for these dominant nodules, we also see they match well in terms of the margin, attenuation, and the diameters. Because some people have multiple nodules, So we also look at all nodules, whether they match well between the case and the control. And this table shows they also match very well. So we use random forest to analyze those data. So here's our analysis strategy. We create about 5,000 classification trees from the training sets. So each tree was constructed using a bootstrap sample of about 2/3 of training data. So leaving the 1/3 of those data to serve as out of bag to estimate the classification error. So then when we develop this forest from the training set, then we apply them to the test set with the 46 imagings. Then we calculate the predicted probability of malignancy score, what we call the PM score. And in this study, we because we restricted our study only to these positive imagings, so all these 46 imagings in the test set, they are all positive. But only 20 of them, they are biopsy positive. So this figure shows our CAD can well separate this biopsy positive and the negative lesions in the validation set with AUC under the ROC curve with 0.91. So then we use a pre-specified cutoff values for these PM scores. We just use 0.5 as cutoff. So all greater than 0.5 we claim as a CAD prediction of positive, and below 0.5 we call it negative. So this table shows the CAD gives us a better prediction accuracy than this NLST reported the report, and also combined the readings from 3 radiologists in terms of these 4 criteria: sensitivity, specificity, PPV, and NPV. So yes, so from this study, we know that because we use matched case controls and matched by all known risk factors. So these samples are particularly difficult for radiologists to classify because those risk factors they used, they are well matched between the cases and the controls. So the higher diagnostic accuracy from CAD is shows that this technique can help radiologists to improve their readings. These are a few examples to show how this CAD could help radiologists to improve their readings. So the first columns, so these are the CT imagings from 3 annual screenings. The first 2 are from the 2 cancer patients. And these 2 patients have very benign looking nodules. However, the CAD correctly classified them as malignant with a PM score greater than 0.5. And these 2 are benign from the participants with benign nodules. And the CAD correctly classified them as benign with the PM score less than 0.5. So then we asked why textual analysis works. We know that the nodule characteristics commonly used by radiologists, such as diameter, volume, margin, attenuation, or these things, although they are important, but none of them are strong. None of them is strong enough to make a good prediction because the significant overlap among these risk categories. Many benign nodules, such as granuloma, they could have malignant looking with spiculated and lobulated margins. We also look at how these textual features are associated with the tumor histology. So we identify a few of them, so, some of those. So here is an example, the CP feature. We find that it is positively correlated with malignancy. So it's a positive, nodules with a high CP score, it's more likely to come from tumors with a small cell carcinoma, papillary adenocarcinoma, and a squamous cell carcinoma. And nodules with the lowest CTP score, they come from normal lymph nodes and a mixed subtype of the adenocarcinoma and the BAC. And we find that this score is positively correlated with the percent of tumor cells. So here, this is how the tumors with a high CP score look like. This is another features we find to be correlated with tumor histology. So it was found to be negatively correlated with percent of tumor cells and positively correlated with percent of inflammatory cells. And here's more examples for cancer, so tumors with, and these are benign and with high-low CP score and high-low D2M2 scores. So here's more example. For those nodules with the highest PM score, they're all cancers, and those nodules with the lowest PM score, they are all benign. We further extend our approach to combine these CT imaging features and with the tissue texture features. So basically, in this study, we focus on those newly diagnosed lung cancer patients with the early stage lung cancer, receive a lung surgery, and we want to differentiate using this CT imaging and tissue imaging textual features. We want to predict who is likely to have cancer progression later on. So this is critical because once the cancer progressed, then most of them will die from cancer. So cancer progression here is defined by either local recurrence or new primary or metastasis. So we apply here just one example how we apply this to our Johns Hopkins lung cancer patients. This is an example from a woman, elderly woman, with initial CT scan revealed 2 indeterminate pulmonary nodules in both sides of the lung. Both are suspicious for lung cancer. So both nodules received the biopsy. The right one, lower one, shows the biopsy positive. It is stage 2B cancer. However, the left one was negative without tumor. So this patient received a wedge resection for the right one, but the left one was followed by CT scan every 6 months. So this patient went 2 follow-up CT scans, and the radiologist reports are stable. However, this nodule progressed to stage 2 cancer 6 months after the second scan. So she received the second surgery due to the delay of the cancer diagnosis. So the surgery resulted in a positive margin, which gives poor clinical outcomes. This is the imaging from this patient 6 months after surgery and 12 months after surgery. And using CAD, we are able not only to detect this lesion start to progress 6 months earlier than the radiologist diagnosis, but also we detect a new lesion appeared adjacent to this blood vessel, which was missed by the radiologist. So this example shows the added value of the CAD to current clinical practice. During the cancer development, the tissue alteration resulting highly packed and ill-defined these patterns and poorly formed granular lumina. And this architecture changes are important patterns to diagnose whether the tumor is aggressive or indolent. By collaborating with Bujwala's lab, we extract the CAD textual features from the second harmonic generation microscope imaging to identify the ill-defined actual cellular matrix collagen fiber to find their patterns. By collaborating with McCullough's lab over Canada, BC cancer agents, we extract hyperspectral imaging features to recognize the tissue architecture changes, cellular components, and their patterns. Here's the example how we do this work. So these collagen fibers from recurrent tumors and the non-recurrent tumors. From these figures, we see that the collagen fibers from recurrent tumors have a higher density as compared to the non-recurrent tumors. And in non-recurrent tumors, these collagen fibers are associated with CD44, expressing the cancer-associated fibroblasts, which is further confirmed by the alpha SMA expression. In this among these recurrent tumors, the collagen fibers textures are not associated with the CD44. However, the CD44 expression was detected from the cancer cell. This figure shows recurrent tumor and non-recurrent tumor. They differ in terms of several collagen fiber textual features, like fiber volume, distance, orientation, and homogeneity. In the hyperspectral imaging analysis, we produce a collection of imagings with a large number of wavelet bands to recognize the tissue architectural patterns. So in this analysis, we adjust for different staining of the tissue, because this, even within the same institution, the staining could differ due to the batch effect. This figure shows how we can recognize tissue architecture and successfully segment that out. We further extract the tissue features to capture this cell-cell arrangement and different type of cell, their architectures from the tissue. So after extract all these tissue features, then we apply the machine learning to these features and develop the prediction model. So in summary, in this study, we've concluded that CAD can quantify, can give a quantitative imaging analysis, then and also can process a vast amount of data information. It provides a better assessment of tumor heterogeneity than human readings. And we conclude that it has the potential added value to clinical practice. So we want to thank NCI to provide us this imaging data, and this work is sponsored by Johns Hopkins Discovery Award and the HN Cancer Research Fund. So this work cannot be done without the contribution from many collaborators. Sava Bushwala and Samantha Kakade, they provide the second harmonic generation microscope imaging analysis. Ilya Fisherman, Russell Hale, and David Ettinger help in the study design. And so Rongkai Yang, Ilya Fisherman, Chen Ning, and Linda Chu, and Amira Hassan, they help in the CT imaging readings. Susumu Mori help in the CT imaging co-registration. Jang Hong Lee and Sion Park help in the imaging segmentation and also in feature extraction. Malcolm Brock help in the clinical input of this study. Christine Rogers help in the tissue management. Matthew Gardner and Natij, they help in the patient medical record extraction. And Peter, Eli, and Edward Gabelson, they help in the tissue pathology imaging reading and interpretation. Steve Lang help in the clinic, also provide a clinical input. And the hyperspectral imaging was provided by Cal Macaulay's lab. Peng Hu, Joshua, and Brad, they help in the NLST image, data extraction. So I'm happy to take any questions.
Thank you so much, Peng, for this great overview of technology and how to use some statistical methods in exploring a finding that's been undercapitalized so far. We have some time for questions. While you're thinking, let me remind you, on your way out, see Nicole here for a ticket for pizza. We invite you to have some pizza with us in the gallery, so, but you are required to have a ticket.
And maybe even required to ask a question to get this ticket.
Here, we have one in the back here.
So Thank you very much for the talk. I'm very interested in that deep learning model, the very first one. So when we compare the result of the human physician and the AI model, since those physicians were trained by hundreds, thousands of extra sources, images, so I'm thinking, is that AI model trained by just that matched around 100 or 200 samples, or is it trained by some other images as well? Will that improve the prediction accuracy?
Yeah. Here's how we use the AI approach to mimic, because you just extract these imaging features without recognize the biology behind the nodule, then these features may not be very robust. So that's how we do this. We said to mimic humans' imaging readings, that we extract the features, not just the inside the nodules, which was done by by a lot of people, at least based on my knowledge. And we extract features from the surrounding areas and also entire lung. That's how the radiologists, they read the images. So that's actually, we combine their knowledge with computers' advance that can recognize the subtle changes in the imaging.
Peng, a question for you about Victor Velculescu's work with the liquid biopsy.
Yes.
Have you
Yes.
made a connection with him and to validate his test and your test
Yeah, this is our plan for the future, for the next.
for the future?
Yes.
Okay.
So I have two questions. One is that what's your gold standard when you evaluate the performance? You use biopsy results or use radiologist reading?
Biopsy, pathology.
Okay.
Yes.
And the second is, what kind of software do you need to extract the different feature from imaging?
So, well, we use different types of computer. All the software we develop by our own, so not a commercial. So written by using C and R.
I'll give you a microphone.
Do you envision it replacing the radiologist? Do you envision it as a marker test? What's the vision for the future?
Our purpose is not to replace the radiologist, though. I think we have not get to that step yet. So our purpose is to help radiology to improve their readings. Yeah, because in this segmentation, we use a semi-automatic segmentation, not a completely automatic segmentation. That means the radiologist just still need to identify this nodule and a single click this nodule, then our algorithm can automatically grow to segment that nodule. Yeah.
So as a software, not an extra test, as if the radiologist was using the software.
Yes. Yeah.
Thank you.
So most of the nodules, I'm here, sorry, in the NLST, many of them weren't biopsied. So I'm wondering, but there's so much follow-up that we know with some certainty that many people never developed lung cancer. So have you applied the algorithm to many of those scans that were positive but never received a biopsy? And how did it perform based on that sort of long-term outcome measure?
Yes, this is another work I did not present it here. We actually now collaborating with BC cancer agents. So this is a Peng study, which is also, hopefully you know, there's a very big study with about 2,000 participants. So unblinded to the patient, this is a patient's outcome. So now we are taking this random sample from NLST and develop using this approach. And we are this work is currently ongoing. We're trying to see how that predict in the Peng data.
To diagnose the lung nodule, how many cases do you think need to build a AI model?
So from scratch or from this. So it will depend on how much knowledge you have about this lung anatomy and the lung disease. We spend several years to do this. Yeah.
So Peng, I was wondering, and this might be a naive question because I'm not a medical person, but are there differences between a regular CT scan and a low-dose CT scan?
Yes. So basically, in low dose means by the words it says the dose pretty low, and the diagnosed scan usually the dose is higher.
So we do find a lot of early stage lung cancers through the regular CT, serendipitously. So, yeah. Other questions for Peng? Over here.
Hi, thank you for the beautiful presentation. You have used some digital signal processing approach like wavelets that have been used to image detection, but associated with that you have used the forest trees. So can you give me how was the approach? The input of the forest tree was the output of the image processing approach. And the second question is related with the exception of the decision approach like you are giving for the clinical is related with if the artificial intelligence tool is a black box or it is not a black box. What can you tell me about that, please?
Yeah, that's a good question. So first one, for the this wavelet, the imaging texture features like a gray level, run length, this matrix, they are frequently used by a lot of people. And we find if we just use these features, we do not reach very high prediction accuracy. So that's why we include other features that radiologists frequently use, as we shown here, from the different regions. Like we capture the shape, like speculation, and also like bronchite cutoff and vessel involvement. Those are the features that are not captured by the wavelet features. For the second one, is how to apply it in the clinical practice. Say it again.
Most of the complaints of the physicians to use the artificial intelligence in practice is that they could not understand if it, because some of the tools are like a black box, like this one, like artificial neural networks and so forth.
Yes. So we also. It's true, the random forest, it's a black box. We really don't know how that works inside. But then the way we approach that is to see how these features are associated with other features from the pathologist tissues, as I show here, for different features, how they work. And also, I have other slides. We show this, so that's filtering, and we see this, like this one, patient with very aggressive nodules, lung cancer, and from the imaging we capture how the blood vessels is involved, and that this is further confirmed from the pathology imagings. You see this patient has a very aggressive tumor with tumor invaded to the blood vessels, and with fibrosis here. So that is how we look at this. Our features, different features are associated with tissue imaging.
One more up here.
Hi. First of all, thank you very much for the wonderful presentation. I was just curious in terms of, have you found that in terms of the algorithms, if there's certain features that are not as predictive and may not be, say, in terms of implementation, you might not need that type of imaging, or certain features that are highly predictive that you would want more resolution in?
Right. So this is two different types of tasks. So in like a biomarker studies, your goal is to identify the biomarkers which are predictive, and then the other one is for the prediction. So markers, even they are associated with the outcome, it does not mean it is a good predictor. Such as, say, we all know this nodule size. It is associated with higher, with the malignancy. But you cannot use that to predict. So this is a biomarker part. And our goal is not just to identify the biomarkers, but our purpose is for the prediction, because this incorporates all these interactions among the markers. Because it's not a single one how they work, but it's how they work jointly.
Okay, I think we'll adjourn. Let's thank Peng for her presentation today.